Well, good morning and welcome to the next session of the ZAP. I'm Ann Schuckett, the Deputy Director for CDC, and want to join in welcoming all of you to this really important day. In this session, the rubber hits the road or the mosquito hits the windshield. To paraphrase a famous politician, all mosquito control is local. And in this session, we're going to hear from a state, city, county, and very crucial territory or jurisdiction that are coping with Zika virus and making plans around Zika control. I think we will have time for questions at the end, and what I really want to do is introduce all four speakers and then get right to it. So thanks for returning, and for those on the side, we do have some seats down in front. The four speakers are Karina Blackmore, who's the Acting Director of the Division of Disease Control and Health Protection in Florida, Daniel Cass, who's the Deputy Commissioner for Environmental Health in New York City, Umair Shah, who's the Executive Director of the Local Health Authority in Harris County, Texas, and Brenda Rivera Garcia, who's the Territorial Epidemiologist for Puerto Rico's Department of Health. And with that, Karina will begin the session.
All right, so thank you so much for inviting me to speak. I will be talking about the coordination of mosquito-borne disease surveillance and response in Florida for a few minutes. And to put this presentation into context, Florida has had a long experience with mosquito-borne diseases. In fact, the Florida State Board of Health was created as a result of a yellow fever epidemic in Jacksonville in 1889. And at the time, we also had malaria and dengue commonly circulating in the state. Mosquitoes also had a major impact on population growth in the state, and not until we had mosquito control districts, we really saw a major growth in population of the Florida Peninsula. The first mosquito control district was formed in 1925, and as was previously mentioned, these are districts either under the auspices of county organizations or independent taxing districts. Because of the importance of mosquito-borne diseases in Florida, we have a strong infrastructure of mosquito-borne disease research in the state, both at universities and the state public health laboratories as well. So the diseases that we worry about mostly in Florida currently are St. Louis encephalitis, Eastern equine encephalitis, and West Nile virus disease. But even though we have better mosquito control and better housing, the vectors Aedes aegypti and Anopheles quadrimaculatus, vectors for dengue and malaria, are still present in the state. So periodically we see transmission of these non-endemic mosquito-borne diseases. And lately we've also seen local transmission of chikungunya fever. Mosquito-borne disease control is very complex. I think we have gotten that message, and we certainly recognize that in Florida. And as a result, we've had an interagency arbovirus task force in place for almost 20 years. This task force includes members of the Department of Health, the Department of Agriculture and Consumer Services, which is the agency that oversees mosquito control in Florida, the Department of Environmental Protection, Fish and Wildlife experts, Florida Mosquito Control Association, Florida Environmental Health Association, the Association of County Health Officers in Florida, USDA, and several universities which have interest in mosquito-borne disease research or diagnostic research. The major output of this group is a document, a guidance document called Surveillance and Control of Selected Mosquito-Borne Diseases in Florida. It provides guidance on public health surveillance and also includes a mosquito-borne disease response plan that is based on data on mosquito testing results, animal testing results, and human case surveillance data. And as a result of those data points, we declare advisories, alerts, and emergencies. We have an associated communication plan that includes routine press releases and other marketing materials, traditional marketing materials, door hangers, pamphlets, etc., and certainly also an outreach through social media. And that's based on our standardized messaging around drain and cover. What really helps our coordination and standardization of mosquito-borne disease response in Florida is the strong infrastructure that we have in mosquito control in the state. The Department of Agriculture and Consumer Services has a statutorily mandated advisory council called the Florida Coordinating Council on Mosquito Control that advises the Department of Agriculture on best practices around mosquito control and also the best use of pesticides for mosquito control. And many of the same partner agencies and groups involved in our arbovirus task force is involved in this council, which provides a good opportunity for further coordination and collaboration. We do also have very coordinated training of the various partners in this effort in the state, both through agencies, but Florida Mosquito Control Association has a great role and wonderful training programs that we participate in. And the University of Florida, the Florida Medical Entomology Laboratory, which is a premier research institution, also has an extension function that provides training in medical entomology. We have joint exercises to exercise response to animal and human diseases of mosquito-borne origin. But because of our location, we do see hurricanes and flooding as well, and these tend to produce major mosquito outbreaks that needs to be dealt with, and we exercise those also. So what is then the impact of this state-level coordination to support local efforts in mosquito surveillance and control? It is a routine, standardized, science-based response that we have in Florida that includes mosquito surveillance and control in response to human and animal cases of disease. For Zika, for example, when the public health laboratory is still the only source of testing, when we hear about cases or suspect cases that we want tested at the public health laboratory, immediately mosquito control is notified and they go out and assess mosquito levels and needs for control around the homes or other areas of exposure. We do further coordinated active case surveillance around outbreaks when we have Aedes aegypti involved in particularly, because as was mentioned, this is a very difficult mosquito to control. It needs involvement from the community, from the property owner, and many times a door-to-door effort that often then is joint between health departments and mosquito control districts in Florida. And we share then the messaging to the public and the press around these efforts. We also benefit from being able to do real-time adjustments when we need in response to activities in the state. This involves conference calls, using the data at hand to really assess whether the appropriate mosquito response is in place or whether adjustments need to be made. This is particularly important when we have new and emerging issues in Florida. So for example, after the 2009-2010 dengue outbreak in Key West, we had a new awareness among healthcare practitioners towards dengue, and suddenly we actually detected local transmission of dengue each year in the state. And although we have a fantastic mosquito control program, probably one of the best in the country in the Keys, one that is very experienced dealing with Aedes aegypti, we recognized that that's not necessarily true in other parts of Florida, because Aedes aegypti is not the typical nuisance mosquito that we worry about most of the time, the mosquito that people call and complain about. So many of the districts were not necessarily doing routine surveillance for this mosquito. We have built a lot of capacity since then, both expertise and trapping resources, and are a lot better prepared today than we were then. We also had a malaria outbreak in Florida in 2003, and at the time we were then able to get technical experts together to advise the mosquito control districts, because Anopheles quadrumaculatus, while present in Florida, it is not a major nuisance mosquito, and it does not really get into the nuisance mosquito trapping systems that we have. So a different response was needed, surveillance efforts need to be modified, and our technical experts could help us with that so we could control that outbreak at the time. With that, thank you so much for your attention. I will turn over to Dan Cass.
So thank you all for having me, and thanks again to all of the people responsible for organizing this important conference. I wanted to talk to you a little bit about our program in New York City and how it's going to be modified. As most of you know, we were the epicenter for the initial discovery of transmission of West Nile virus in the continental United States about 15 years ago. So I'm going to start by talking about the elements of our existing mosquito control program, how we expect to modify it, and what some of the considerations are for that modification. Like most mosquito control programs, ours is really grounded in an integrated pest management approach. And I will be talking about each of these essential elements. But our response involves a tremendous amount of community engagement, extensive employment of the use of larvicide, both in aerial, non-populated areas, as well as ground-based for populated areas. And we carry out truck-based adulticiding in areas of the city where criteria are met based on disease-based thresholds. So just to quickly run through a handful of slides so you can get a sense of the reach of our current West Nile virus control program. We do extensive community outreach targeting neighborhoods and populations at elevated risk of West Nile virus, nursing homes, naturally occurring retirement communities, other vulnerable populations. It includes direct outreach, distribution of educational materials, spray notifications, and some repellent distribution. Our surveillance program is really built around trying to detect Culex mosquitoes. We have 61 permanent trap sites deployed strategically across the city with the locations optimized for their detection based on both habitat and historical patterns of the spread of these mosquitoes. When a mosquito pool tests positive, we deploy supplemental traps in a geographic area surrounding the positive pool to determine the geographic reach and the extent of the population itself. We have a 311 service to report standing water complaints, and we do proactive inspections in a variety of settings as well. Last year, we had about 1,700 complaints that resulted in about 1,500 inspections. We have the authority under some modifications to our health code and commissioner rules to issue notices of violation upon first inspection and to treat where we're successfully able to gain access. We do extensive ground larviciding. Based on our 15-year-old surveillance effort, we do routine treatment at more than 800 locations, including cemeteries, parks, ponds, and areas with natural depressions. Over the course of the mosquito season, we apply larvicide at nearly 5,000 other sites, and our larvicide has until now involved the use of bacteria-based Vectobac, Vectorlex, and Vectomax. This is a map of the catch basins in New York City, each of which is treated at least twice each mosquito season. These are important breeding sites for Culex mosquitoes, and this is one of the few areas we rely on contracting work in New York City to conduct. This map is a nice summary of what happened in 2015, just so you can get a sense of the scale of activity upon which we intend to build a modification for addressing Aedes mosquitoes. The shaded areas are areas where we adulticided at least once. The red dots are areas where we had positive mosquito pools. The stars are where we had human cases. We know that last year we had about 31 adulticiding events, which covered about a third of the geographic area of New York City, where there were home to more than 800 infected mosquito pools. It was a very rough year for us, both in terms of West Nile virus burden as well as programmatic. I include an image here at Dr. Frieden's request of the helicopter that the health department uses. Back when we first began this program, my predecessor in the job happened to be a helicopter pilot and made a convincing case for acquiring a helicopter, which was really fortuitous, because if it happened under my watch, we would be operating either from the back of a bicycle or a Mazda hatchback. So what we learned a variety of things over the course of the West Nile virus response that's really helping to inform the work that we do. And I want to just cover these in some detail because they're important. The first, the public, while hardly monolithic in a diverse city like New York City, did strongly object to aerial adulticiding in the first year of our West Nile virus control program. Now, granted, we were using malathion, but I think the objection would carry forth anyway. They're far more accepting of truck-based adulticiding, but I think it's important for local control programs. That's based on our communication and their strong trust in us that this is a disease risk-based decision that's made to balance potential harm and potential benefit. So that's going to look different. A challenge going into the year where we plan to substantially expand our work is that when the city itself conducts the work, things go better. And in any effort to try to expand rapidly, that becomes a challenge both in terms of resources and in terms of being able to manage the burden. There's very poor predictive power year to year about what we can expect in terms of positivity in mosquito pools and the extent of the actual level of response that we need to have. So we maintain a robust surveillance system, and we have staff that we borrow from other programs as needed. We do provide a great deal of reassurance to the public by using our syndromic surveillance system and our poison control center to track in near real time whether our adulticiding program results in inadvertent exposures or negative health outcomes, at least as we can detect from those systems. We're happy to say that in the last decade we have not had any adverse outcomes, and that's important going into this season where everything will be expanded. And finally, as you've heard all morning long, community engagement is critical to all of these efforts. So we have had a very robust response to date in terms of planning. These are sort of elements of all of, or many of your states and cities that are responding, as well as the CDC. This slide is a bit out of date. This dates to the middle of March, but so far, just to give you a sense, we've spent well over $3.5 million in preparation. We've conducted well over 1,600 lab tests at our public health lab with human specimens. We've detected 25 Zika infections in returning travelers to New York City, 3 of whom are among pregnant women, and we expect to be doing much, much more. So there are a variety of factors that we're really thinking about in terms of mounting and writing and publicizing what will become a final Zika control plan, or at least an interim one for this coming mosquito season, and I want to kind of talk quickly about what those are. First, I want to be really clear, New York City does not have Aedes aegypti mosquito. In 15 years of mosquito monitoring, we've tested over 1.2 million mosquitoes. We've speciated them. We've never found Aedes aegypti, understanding that things can change, but we're going into this anticipating an Aedes albopictus control program. Each year we have hundreds of cases of dengue and chikungunya cases diagnosed among returning New Yorkers who have traveled. That gives us some reassurance that there has never been a case of locally transmitted dengue or chikungunya in New York City, and so we're hopeful that going into this season we will not see established populations of infected mosquitoes with Zika. We know going into this season that public concern is far greater for Zika than it has ever been for West Nile virus, for obvious reasons in terms of the population at risk and the consequences. And in terms of making decisions about how and where to do control strategies, we're really conscious of the fact that most infections are asymptomatic, suggesting that the transmission to a local host can occur without the knowledge of the location. Local transmission could occur without prior detection in mosquitoes. Human testing is limited, driven by concerns about pregnancy and emergence of symptoms, so Zika could be transmitted to mosquitoes in areas where we do not have people being tested. And in the infectious period in any person often passes prior to the availability of test results with which we can make spray decisions. These I won't go over in detail because you've heard them all morning long, but the fact is that Aedes looks quite different than Culex does. This is a map, side-by-side map, for example, of the known distribution on the left of Aedes albopictus in New York City, which we have not historically controlled for, compared to the right, which is Culex pipiens, one of the leading vectors of West Nile virus in New York City. And you can see that there is, they're largely inverse of each other. So we know that our program, as it takes shape, will have a variety of elements. There will be increased outreach and complaint response to control breeding populations, increased distribution of repellent. We'll be dealing with many novel neighborhoods in New York City in an Aedes control program. We will be deploying new traps to improve at least our estimation of the magnitude of the problem with Aedes mosquitoes. And we will be using a new arsenal of pesticides, including methoprene, which is an insect growth regulator, and a newly registered product in New York State, Duet, which allows us, we think, to be effective against Aedes during nighttime spraying because of the exciting agent. We'll be using some new ground larviciding techniques, and we will be modifying our decision logic for pesticide applications. No longer do we expect to use disease-based or positivity, mosquito positivity to really guide it. It will be driven principally by the presence of Aedes mosquitoes, and we do expect there to be a lower threshold overall for community-level response than we have for West Nile virus. So thank you very much. With that, I'd like to invite Dr. Shah to join us.
Good morning. It's great to be here today. Just wanted to, first of all, thank the CDC and sponsors of this great summit, and also partners that are in the audience, many of whom it's great to connect with today, and certainly my fellow panelists. So I'm going to speak very quickly. So although I'm from Texas here, I'm going to do my best to go as fast as I can. So please bear with me. Responding to Zika, a local Texas public health perspective. And so as was mentioned by Dr. Shukit, I'm the Executive Director for Harris County Public Health and Environmental Services, the County Health Department in Harris County, Texas. We're home to the third most populous county in the U.S., which is spread over, interestingly enough, a geographic area that's larger than the state of Rhode Island, with 1,778 square miles, with 4 times the population. We are diverse in every sense of the word, and growing in every sense of the word growth, and are home also to an incredible amount of resources, with the largest medical center in the world, but certainly have our challenges. Mosquito control in our community is very much grounded back in the 60s with St. Louis encephalitis. The Harris County voters voted in a mosquito control district in 1964. We went to operation in 1965, and last year we celebrated 50 years of fighting the bite, if you will, primarily against the Culex mosquito, and have gone through our nationally recognized program a number of milestones, including in 1985 characterizing Aedes albopictus first time in the continental U.S., and the early 2000s when West Nile virus was really where we needed to start to shift much of our attention. But over the last couple of years, we've started to now, with dengue and CHIKV, and also with Zika, have started to move into the realm of the Aedes mosquito. And so you can see some of the real activities that are very much about what we've been doing for the last 50 years. And I think it's really important for us to remember that a lot of this is going to continue to be in play as we think about the fight against the Aedes mosquito outside of the avian surveillance piece here that's listed in the top left. So our approach to Aedes is very much about knowing what's happening with the vector. And as you can imagine, I don't know how many folks in the audience have been to Texas, but we do have a climate that appears to like mosquitoes or helps to breed mosquitoes. And that's something that really is something that we need to be aware of and also understand as we shift from primarily a Culex-based mosquito control program to also the incorporation of the Aedes mosquito as part of what we're doing. And that means emphasizing a number of different things that you've heard all morning around source reduction, personal protection, and certainly public education. But what we're also doing is to really bring those principles of One Health and health equity as part of our approach to Aedes. And that really is very important for us. So from a health equity standpoint, we know that if we go to certain segments of our community and say that it's easy, for example, to just get screens on your windows or repellents and just go out and do this, that it's really nuanced. It's not as easy in certain populations that we have in our communities. And so we need to really understand the socioeconomic factors, literacy, access to care, access to health information, et cetera, that really is in play with that. And then we would be foolhardy at our department if we did not utilize some of the fantastic human health vector control and animal health that we have at our department, we're fortunate to have. So to integrate those together is really part of what we do, and certainly part of our new multidisciplinary team that we have put in place so that we can do some targeted interventions depending on what's happening in our community. But it's not theory to just theory, it's actually theory to practice, because January 11th, we had the first Texas traveler case of Zika, and so it was very early on. And so obviously we were working on this even before December was over and the holidays, et cetera, because from our standpoint, it was really that we needed to be very, very cognizant of what was happening, not from a theoretical standpoint, but very quickly we were in the midst of response. And that response meant that we were getting international and national attention. We had to come very up to speed on what was happening with Zika almost before we got to the point of being able to even look at some of the response levels that you see that are highlighted here. So level 4 all the way to level 1 for us is really about how do we go from travel-associated Zika, where there's no local transmission, all the way up until you have widespread Zika from a local transmission, or that you have widespread Zika that's found in your mosquitoes. And certainly our response team that I have to really give an incredible amount of kudos to was a part of this real opportunity of coming together in a multidisciplinary approach. And I would really say that multidisciplinary approach is the only way and the best way to go about doing this. The other thing I would just point out now is that as we look at these levels, there are going to be incredibly different kinds of responses and resources that are going to need to be positioned as you get into those levels. And so from that standpoint, mosquito control and communications are where I'm going to focus on very quickly. From a mosquito control standpoint, obviously you've heard that we have limited data from a historical standpoint on the Aedes mosquito, and so we are expanding our surveillance efforts from a trapping standpoint, while we're also looking at how do we do predictive modeling as part of that. And key metrics for our mapping are listed here, but I have to be honest, it's really how do you layer all that information together in a real focused manner, while we also beef up training, equipment, materials, and partnership with our community and our partners. These are some pictures of our traps. As you can see, there are some traps that are very much about Aedes mosquitoes primarily, others that sort of get both, others that get the Culex mosquito, and we're also looking at the AGO trap that was mentioned by Dr. Cass to really appreciate what are the kinds of things that we can do so we have a better idea of what's happening with the Aedes mosquito population in our vector species. And it's not just about the traps, right? It's not the dollars to pick up the trap. It's the person on the right that you see. It's the people that have to go pick up the traps and the testing materials, et cetera, that really are key areas of how do you increase your surge when you have additional activities that are part of that. And you can see this with our mosquito control areas, that we have divided up our 1,778 square miles into 268 mosquito control operational areas. And you can see in yellow and blue where we have traditionally been doing trapping for the Culex mosquito, but now adding in what is really very much a part of our plan for the Aedes mosquito. And I have to say that there are some resource constraints, again, not just about the trap, but actually on the resources to actually help with the increased workload that goes along with the trapping. Let me segue into communications and say that this is a key component that you've all heard about today, and so I won't belabor this, but to say that as we look at our campaigns and the real partners that are part of this, we see the media and really a number of different agencies that are part of what our strategy is moving forward. That also means we need to be culturally appropriate, we need to be in the languages that are a part of our community, and we need to really be thinking about how we can best engage our federal, state, and local stakeholders. And this is the point where I do a shout out to my colleagues at NACCHO, National Association of County and City Health Officials, as well as colleagues who are here with the Texas Department of State Health Services, and a particular shout out to local health officials in Texas with the Texas Association of City and County Health Officials, TACHO, because we all have to work on this together. We can't get through this by ourselves. And the other thing that I wanted to point out in this is that social media and engagement of our community is an absolutely critical piece of this. Other focus areas, and I, again, won't belabor this, as you've heard this throughout the day, are really around episurveillance and testing, healthcare provider, clinician outreach, environmental and veterinary public health, legal review and authority, and emergency preparedness and response. And these are areas that we think are very critical to our multidisciplinary approach to the Aedes mosquito. So let me close with the last two slides here about our response challenges. First is that the situation related to Zika continues to evolve. I think a couple of months ago, none of us would be thinking about, we were going to be talking about sexual transmission in the way that we talk about today. And so we have to stay humble, which I think is a really important point that Dr. Frieden made this morning, that humility is such an important piece of this. We do not have everything figured out around Zika and the Aedes mosquito population, but we need to be continually watching what's happening as the situation evolves. We also cannot spray our way out of this situation. That's a quote. It's my quote, so I put it in quotes. It's up there. But just to let you know this is that we can't do that, right? So we have all the other source reduction and education and personal protection, because this is really about not the truck coming in the middle of the night that's going to be able to get rid of the Culex mosquito. It's how do we bring the Aedes mosquito on top of the Culex-based approach that we have already. And we need to have a broad-based platform of doing that so we have efficiencies and our logistical issues are taken care of. And finally, I do want to make mention of the fact that what Dr. Peterson mentioned about mosquito control districts. Our program, though a great program, is 98% funded by local dollars. To me, that's provocative when we think about arboviruses and mosquito control activities in a community such as ours. And so I just want to put that out there as well. So let me close with this last slide that just this is a picture from 2005 Katrina, an official ICS Form 214 that I put in. It wasn't for widgets and things. It was actually for common sense. And yes, I had a lot more hair then, and it was not gray, it was black, so I get that, but that is me. And I want to remind us that really the role of public health, and not just public health, local public health just makes common sense, because at the end of the day, health really happens in local communities. And this is a picture of our Zika response team, and I'm very proud of the work that they do, including Dr. Mustafa Daman, who is our mosquito control director, who I really appreciate his efforts with our vector activities here in Houston, Harris County. Thank you so much.
Buenos dias. I echo my colleagues' sentiments of gratitude for the opportunity to present Puerto Rico's work here today. And Umir, I will try to give you a run for the money. So one of the most effective ways to get protection tools in the hands of pregnant women and those of childbearing age is through Zika prevention kits, or CPKs, like the one pictured here. In Puerto Rico, distribution has been mainly through WIC clinics. We're also just delivering these to OB-GYN offices in the areas of active Zika transmission. Additionally, we're in conversations with drugstore companies to deploy CPKs when women purchase pregnancy test kits. There have been various iterations of these kits, but the constant components include insect repellent, preferably 25% DEET, bed nets, condoms, and culturally competent educational materials. Prior versions have included thermometers and larvicidal dunks, but these have been removed due to mixed reception. Some components are illustrated here, as well as the map of the initial week of CPK distribution in WIC clinics in hot zones for Zika transmission. One prevention activity that has met with mixed success is temporary screening. Many Caribbean cultures like to take advantage of the balmy leeward breezes. Thus, screening is not widely used. The plan has been to acquire various materials in relatively low numbers and price ranges and pilot them, testing the viability given the different window and door styles and frame and wall surfaces. The kit picture here is one example which was actually not very successful, as staples do not tend to work in concrete walls. And duct tape is not very resilient given the high humidity and temperatures in the island. As mentioned today by many of my colleagues, it is important to understand what are the competent vectors in your area. It is also important to understand insecticide resistance patterns. This information should help determine available and most effective delivery methods, such as ultra-low volume truck-mounted spraying, indoor fogging, insecticide treatment of curtains or bed nets, indoor and outdoor residual spraying in the homes of pregnant women that express interest and give consent to undertake these activities in their homes. In Puerto Rico, we are also giving consideration to aerial spraying of larvicides, such as natural BTI. However, we know that acceptability of widespread insecticide use and various delivery methods can be an issue among the general population and the scientific environmental community. Furthermore, it is important to ponder rollout logistics, to outsource or to use existing control vector programs, how to engage high-risk populations and communities, how to design messaging on insecticide use and delivery methods, as well as coordinate services and give consideration of federal and state regulations and permits and financing. Much has been said about acceptability. Are interventions acceptable? Are messages culturally competent? Do they resonate with your population? Puerto Rico has been dealing with Aedes aegypti for over 40 years, to the point that some accept dengue epidemics as a fact of life. Our population is knowledgeable as to what activities are effective in mosquito prevention and control, and do have positive attitudes. However, these activities are not quite yet we're not actually there on undertaking those behaviors. Thus, with the collaboration of our CDC colleagues, we have undertaken behavioral studies to understand what messaging or activities can help us actually effect behavior change. We'd also like to understand acceptability and usefulness of the CPKs and their components, what interventions are pregnant women comfortable with and willing to accept, and what messages work or not. This information has and will be used to revise and design messages and identify potential spokespersons and champions on mosquito bite prevention. One message from pregnant women that is very clear is that they want community involvement. It is also very important to have a strong communications plan and team, not only to address educational messages, but to communicate in plain language the spectrum of vector control interventions and the risk of sexual transmission, to assist also in designing how to best present relevant surveillance data, and certainly to assist in how to handle communications with the various media outlets. Now, the next few slides do not necessarily address vector control. They address other important planning and preparedness activities in any Zika response, which were actually touched on by our previous panel. Epidemiology capacity and modification or implementation of surveillance systems are indeed necessary and very needed to address all the issues at hand. In our case, it was relatively easy to modify our passive surveillance systems for dengue and chikungunya to incorporate Zika. Now, this makes our surveillance system one of passive arboviral diseases instead of siloed dengue or chikungunya systems. We also have a Zika-positive pregnant women surveillance system. However, as explained by Dr. Bell, it differs somewhat from the registry implemented nationwide, as ours is an active system where we undertake medical records abstractions and follow-ups. It was very important to also incorporate congenital microcephaly in our birth defect surveillance system. This in order to understand and track potential adverse birth outcomes associated to infections during pregnancy. Additionally, we have implemented a Guillain-Barré passive surveillance system to better document the true relationship of GBS and Zika. And lastly, as a Zika screening test for blood units has become available, we will implement a surveillance system to track potential Zika infections associated to blood transfusions. It is important to understand that these tasks go beyond the design and implementation of the system, but that all that comes along with it, education and outreach to clinical communities, preparing materials that clearly explain the purpose of and how to report to the systems, retraining key hospital staff on critical activities, just as how to properly measure head circumference and body length in newborns, and also informing preparedness plans for healthcare services. Needless to say, the implementation or modification of these surveillance systems can stretch the EPI capacity of any jurisdiction, so planning on how to best allocate limited resources is a must. Another key component is that of laboratory capacity. We're fortunate to have the dengue branch in Puerto Rico. Our strong partnership has placed us in a position to help validate the RT-PCR trioplex, making us the first jurisdiction to have this very valuable and useful tool. This test allows us to simultaneously test for dengue, chikungunya, and Zika with a single sample, reducing testing turnaround time for results, staffing needs, and costs. RT-PCR technology will not be useful, however, in the diagnosis of asymptomatic women or individuals who are over 7 days post-symptom onset. Thus, testing for these individuals will require Zika IgM testing, which, as we have heard, is very complicated and time-consuming. It is also important to understand that in jurisdictions endemic for dengue, IgM testing for dengue is also necessary, and a higher number of cross-reactivity should be expected, adding an additional level of difficulty to interpretation of IgM positive results. And finally, for us in Puerto Rico, it is very important to increase the range of contraceptive options for those women of childbearing age who do not wish to get pregnant. Of particular interest are long-acting reversible contraceptives, or LARCs. Unfortunately, LARCs do not have a high uptake among Puerto Rico's women. So we will be conducting a behavioral risk factor surveillance system survey in the next few months to better understand women's preferred options and potential barriers. Those results should guide future interventions among both men and women of reproductive age and provide guidance to healthcare providers. As stated by Dr. Frieden, we do not know how to prevent possible adverse birth outcomes related to Zika, but we do know how to prevent unintended pregnancies. And with that, gracias por su atención.
Well, I'd like to thank all the speakers and now transition to a brief question and answer period. So reminder that there are microphones on both sides of the room. We have heard about coordination and multidisciplinary teams. We've heard about building off of strong West Nile programs and the critical issues of health equity and vulnerable populations. And I think we also had a really rallying call to common sense. And so I think you can see the wisdom that is present at that local, state, or frontline level, and a chance for the audience to probe a little bit further. Jeff?
I can thank all the panelists. My name is Jeff Engel, Executive Director of the Council of State and Territorial Epidemiologists, one of the many NGOs represented here today. One of our biggest jobs is to advocate for our constituency. In my case, it is the state and territorial epidemiologists who are responsible for surveillance, both on the human and vector side in this response. So the concern is the recent $44.25 million that was cut from the Public Health and Emergency Preparedness Grant, which actually funds those surveillance programs in the states and territories. And we understand that much of that money is going to Puerto Rico, and we understand the need, and we're not faulting the CDC either for that, because it was, they had no choice. So my question to the panelists is, are you meeting with your local federal officials, federally elected people, senators, House of Representatives, to emphasize the important need for the Zika supplemental funding? Thank you.
Thank you, Jeff, for that insightful question. What I would say is that this is really one of the biggest challenges for us, is that we have to remember that funding needs to be broad-based, and broad-based means arboviruses, but a number of public health emergencies and preparedness for that, epi response, or in the midst of a hurricane, the other activities that are very much a part of that. So on the one hand, we're saying Zika is really critical and we need to put resources there, and so we're adding for additional dollars there. On the other hand of our body says, but but our broad-based platform of emergency preparedness funding is actually going to be cut. And it's a nonsensical, it's just a zero-sum, it does not get us further. And what we need to do is really be thinking about how do we have the broad-based platform of funding while we also accentuate funding and activities and policies towards the disease of the day, because obviously the other diseases and other activities are also a part of that. So yes, we are getting that message through, and any help that we can provide for that, we would be happy to do that.
I'll just end by saying that the advocacy that we're doing in Washington can only be helped by the local advocacy that only you're able to do. So thank you very much.
Next question over here.
Hi, Oscar again. I just switched sides, so it seems like I was. So I'll try to make it as quick as possible. And this is primarily to Dan and to Umair. Could you please explain the infrastructure costs, the difference in what it will cost or what it has cost your entity to shift from the regular allocations for West Nile for production against West Nile or surveillance against West Nile versus what you anticipate for Zika? For example, the change of the traps and the change of catch basin treatments or all those types of things. So is there any way you can articulate that for the benefit of those who don't necessarily get that?
Thanks. It's a good question, and I would say, to be really candid, it's a work in progress. As you can tell from my presentation, we're working off of a lot of uncertainties. We don't know how many there are. We don't know whether we're going to, ultimately arrive at a place where we have local transmission, either individual cases or clusters. We don't know a lot. So I can say a couple of things. The first is our preparedness work is really built off of the infrastructure that we have from the FEP grants and other activity. That's cost us, as I mentioned, sort of over $3 million in staff time just to kind of manage all of the response, mostly on the clinical and the testing side. We're building estimates right now of what our program will look like, and we're imagining trying to staff up at a level that would allow us to at least sort of treat and respond to large AIDS populations with many people at risk, many people returning with Zika, and a scenario in which we anticipate local transmission hitting somewhere in the continental United States, which influences the level of concern and panic. And we think it'll cost us, on the order of about $5 or $6 million additional a year in New York City.
Thanks, Oscar, for that question. For us, it's the challenge is very similar to what Dan just mentioned. Is the real concept of the unknowns. There's so much we don't know. We don't know, as I mentioned, the response levels. Are we going to stay in response level 4 for 6 months, 2 months, 8 months, 12 months, 2 years? We don't know what that's going to mean, and that slope really helps determine how much funding and resources that would be in play for us. We're estimating, and any estimate is actually, I think honestly, the moment I put a number out there, I'm going to regret that I even put a number out there. So maybe I shouldn't even say whatever. Yeah, he started. So I would say about half of what he just said is what we've been estimating. But the real challenge is that a lot of our daily work has now been moved to the side and shifted to other activities. So you see up there, I've got Twitter, I tweet, I'm one of the docs out there that tweets, USHA-MD, no plug here. But just to let you know is that a lot of my tweets right now are really very much about Zika. A lot of my communications folks are sending out information about Zika. A lot of my epidemiologists are working on Zika. The real outreach to our clinicians and our health alerts that we're sending are about Zika. So what it's doing is that it's starting to become, it's really pervading, becoming pervasive throughout our activities throughout the department. And so it starts to become harder and harder to quantify the delta over broad-based emergency preparedness and response activities in addition to the surge that we're doing with Zika. But I would say just about half of what he said is probably a good ballpark for us. Thanks.
Next question over here.
Yes. Sarah Conti from the Department of Health and Human Services in Raleigh. Thank you for having us. 2 things that I'm not hearing and I wanted to bring up is hopefully some allocation of funding specifically for EMR upgrading. That's something that we struggle with in North Carolina. We have lots of local health departments, and to go back into those systems and add the Zika question or any other additional question is very expensive for them. So that's my one comment. The other, I like what I just heard from you, Dr. Shah, was social media. So we're talking about a population of childbearing. You're talking about high school, you're talking about college. You know, we need to get out there and get in social media, because if we can educate, having a daughter that's just away at college for the first time, these are things that they educate themselves and that I've actually heard her come back and say to me, so tell me about Zika, Mom. And that's okay, because you know, it's important to educate our obstetricians, but my daughter hasn't seen an obstetrician yet. So she might not get that information. So I think those are important pieces. I know that I've seen the WHO app and also the American Academy of Pediatrics app, but I don't see my daughter going to subscribe to that app. So I think those are two really important things that we need to think about. Thank you.
Having spent the past few weeks doing things like Facebook and Google Hangout and Tumblr talks with Amy Pope, including the spring break college newspapers, I think there is an effort to get our communication messages to a diverse group of folks who are traveling or folks who are at risk for unintended pregnancy or of course, the clinical community. I do wonder if some of the local and state folks want to talk a little bit about other activities that you're doing in that arena.
I would just add, in addition to, you know, an emphasis on social media, we'll be launching a new ad campaign in just a couple of weeks that'll be sort of both social media based as well as print media. But we have a lot of outreach that's going on right now into communities in New York City that travel. We have a tremendous population of foreign-born. We know, sort of the neighborhoods in which people are most likely to be moving back and forth between the Caribbean and Latin America and South America. And so there's been a lot of boots on the ground there as well, doing site visits, community organizations, poster hanging, that kind of thing.
Yeah, and I would like to add that in the absence of large amounts of money for large educational campaigns, social media tools have become very important, and that's one that we have relatively easy access to. So the Department of Health has been very adamant in pushing out social media messaging for various populations, for the traveler population, for the local population, pregnant women, the younger age groups, and of course men, and on how to protect their partners from potential sexual transmission. And we've been doing this through Facebook and Twitter. Of course, they're in Spanish, but you're welcome to visit.
And we have, and I brought Prevent the Bite Day and Night, one of our materials here, and we've shifted from the real, again, the nighttime activities of, you know, dusk and dawn and all to really, it's almost 24/7. Really that's what we're getting at, right? So the challenge we're going to have, and this I think is something that we're going to eventually get to, is there will eventually potentially be fatigue when the messaging gets out there so much. And now we're going to have to really shift to different kinds of strategies so that we can continue to emphasize the importance of the message. And that, I think, is going to be, we're not there yet, but I know that is something that we all need to be cognizant of as well.
And I mentioned our social media outreach in Florida, Facebook, Twitter, Flickr, we do YouTubes as well, try to do it using a standardized message around drain and cover. And that's partly why we have our advisory and alert and emergency system, that those are standardized triggers then that provides new information and hopefully new attention to the issue rather than just sort of randomly putting out messages to our constituents.
And I think there's some aspects of this that are quite similar to influenza work, where at different locations at the same time, there are going to be different situations. And so CDC is very committed to supporting consistent, evidence-based, risk communication and core messages, but at the local level, you're going to have a different context, and that's why some of these tools are quite important.
If I could just make one, that's a great point. So we oftentimes say that we need to have the same messaging. We actually need to have consistent messaging. It's very different. And I want to point out that we had in Texas, Texas Department of State Health Services partner with our new Commissioner, Dr. Hellerstadt. They're really looking at how to communicate better across the system, which is the best way to do this, which then allows local health departments, local mosquito control programs to really build into what the statewide messaging is. And I've got colleagues here from Dallas County and also from Tarrant County and Austin, Travis County, and other parts of Texas. And they're really very much about YouTube and trying to get information out and new ways of really approaching what we're trying to do. And I think it's really key for us that we have that consistency across the messaging.
Okay, I'm getting some signals here. So I do see a lot of people at the microphone. So I think we could take just one question from each side. I do want to mention there are going to be opportunities in the breakouts and the lunch to probe deeper in many of these issues. So over here first.
Thank you. Abelardo Moncayo from Tennessee. Buenos dias. I want to make a pitch for Aedes albopictus. I was glad to see in New York that you're worried about Aedes albopictus. Lessons from Tennessee. We have had recent emergence of La Crosse, and recent being 1997. And this emergence has also occurred in North Carolina and West Virginia, areas in the Appalachian regions, which are impoverished areas. And we believe that it emerged there because of Aedes albopictus. So we have a mosquito that has contributed to the emergence of a disease that we were already seeing. With respect to Zika virus specifically, in Gabon, it was the outbreak there was driven by Aedes albopictus. And in fact, the only mosquitoes they found positive were Aedes albopictus. There have been other examples of Aedes albopictus being involved in Zika transmission. So I think it's very important to do Aedes aegypti surveillance or surveys in various states. But at the same time, we already have an important vector that we should keep our eyes on.
I just want to make a quick comment. I think that we are working under the assumption that it's a mosquito of concern. We don't know that it's a competent vector, so evidence to date has demonstrated they can acquire the virus. There's little evidence at this point to suggest that in settings in the continental United States, it may in fact be a competent vector, but I think it is right to prepare for it.
Last question here.
Bob Eady from Key West, and my comment is more than a question, but I would think that while everyone was here, it is something that's really worth considering, that we have a very robust mosquito control in the Florida Keys. We have a good health department, I hope. The Harris County has a fantastic health department, and you see they have an incredible mosquito control program. It is ironic that you have those two elements, and yet in Key West we had an outbreak of locally acquired dengue that went for months, and then you see the first Zika case that was sexually transmitted. My point just being that it is the people that we serve that are living in the local areas that we've got to make sure that we keep focusing on. And the thought that it needs to be on a local level, the consistent messages, and also when the resources are being thought, they need to be, how do we get them to the people and how quickly do we get them? Do we get them there, like laboratory testing for local health departments, things like this? And the other comment, I think that you will see, like based on our Key West experience, and hopefully not in Zika, but it's a long haul issue. I wake up every day wondering when that we'll have dengue again. because everything was there, and the same thing could be with Dr. Shaw. So I just think local, I guess, is what I'm trying to point out.
Thanks so much. I want to just close this session by thanking each of the panelists and reminding us that today is about planning. There's a huge amount of expertise and experience in the venue. We hope that the next sessions that you have give you a chance to get even more detailed in your planning efforts, and we really do want to be ready for anything. There's been nothing about Zika that's been easy so far, and there has been a surprise, a moment. So I think that concept that we can't be complacent, we can't burn out our communities, we have to be ready. People are expecting us to, but we can't overpromise about how easy this is going to be. I think, so I'd like to have you join me in thanking the panelists